Unmute there. Okay, great. Thanks. Welcome to this second research session. I just want to pick up from the last session. There were a lot of questions people still had. There are a lot of questions online to those of you who are following online. Each abstract should have their own page on the COP. And please follow up with the questions that are not answered here on that site. And I tell the presenters to follow up there in a day or so, whenever we have time to continue answering questions. This session we have three presenters. We have Karen first on effect of lockdowns on fertility. And then we have Yoshito Kawakazu from UNICEF on climate hazards and MNCH service delivery. And then we have Donat from Ifakara Health Institute presenting from the Impulse study on newborn and stillbirth data from CAR in Tanzania. So I'll give the word now to Karen. So, thanks.
Great. Is that all right? How do I put this on my ears somehow? Yeah, okay. So is there a clicker or how does it work? Is there a clicker? Like use this. Okay. Fantastic. Okay, so good afternoon, everyone. Thank you so much for coming. My name is Karen Greppen. I am a faculty member at the School of Public Health at the University of Hong Kong. What I'm going to present today is a paper that looks at the impact of COVID-19 on fertility and birth. So I'm a health economist. I do research on health systems broadly, but I'm also quite interested in developing methods to use DHIS2 to do kind of the types of studies that we as health economists like to do or health systems researchers like to do. So this is an example of what I'm going to call research with DHIS2, right? I know a lot of the people in this conference here are here to learn about DHIS2, work with DHIS2. I think if I'm correct, the sort of theme of these lightning talks is to give examples of how we're starting to use DHIS2 data for other types of research. And so I hope that's what you've signed up for and what you're here for. And what we're going to talk about. And also, this is a lightning talk, which I think that means it's supposed to be pretty quick. So I will kind of gloss over some of that kind of more technical economics type stuff in this because I want to sort of emphasize a bit more on the data. Okay, so this works. And by the way, I finished these slides on a flight from Hong Kong, and I realized when I was just proofing them, there's a ton of typos in them. So free points for anybody who identifies them. And I'm not clicking correctly. Do I just hit the space bar? What do I do? Ah, that one, okay. Okay, so no need to remind anyone in this room, COVID-19, this was a big event. This had all kinds of implications in terms of the way in which we lived our lives. And not only did COVID-19 itself have impact, but the way in which governments responded to COVID-19 also influenced this, right? And so profound health, social, and economic effects. There is a well-established literature that has suggested that health services were disrupted in the context of the pandemic. And by the way, a lot of the research on this actually comes from DHIS2. So we have lots of great examples of how, for example, countries have used DHIS2 to do the short-term, temporal, very dynamic evaluation of what happened to health service delivery in the context of the pandemic. If anything, I actually think this was actually a huge moment for DHIS2 because it suddenly had this dynamic temporal data that we were able to like really get disaggregated views about what was happening in real time with a slight delay with regards to service delivery. What we do know is, for the most part, MNCH services, no matter where you were in the world, were largely disrupted in a negative sense. And this includes, of course, family planning services. So if you were looking to help control your fertility in the context of the pandemic, we might expect there to be important declines in this. And so as an economist, I would say that would probably lead to increased fertility. At the same time, too, as an economist, we know that one of the things that feeds into whether or not people want to have children or not is economic conditions. So when there's a shock to your economy, it's likely that you would have more uncertainty with your wages and so on. And that would actually lead you to a decline in your desire to have children. And so you can see there's kind of this trade-off between reduced access to family planning, which would drive up your fertility, and increased uncertainty around economic conditions would actually reduce your fertility. And so it's sort of an ambiguous question about how this would actually play out in the real world. In addition, public health and social measures, for example, lockdowns, this is the first of my major typos, the incomplete sentence here, would also feed into this. And so a lot of what we know about this kind of shocks literature comes from other types of public health events, earthquakes or other types of short-term emergencies. What was also very unique about the pandemic was the way in which we imposed these additional measures, and those themselves could also have big impacts on these fertility outcomes. So early in the pandemic, a really influential model was put forward to sort of try to think about how these things are. I don't want to get too much into this because this is the economics that you guys are not so interested in. But this middle section here, which looks at, for example, urban centers in low and middle income countries, very ambiguous in terms of how the pandemic would play out in terms of fertility. In these contexts, in all contexts, we would assume that family planning access would go down, but this economic uncertainty, that could balance out. And we don't know how that would play out in a place, in a little rural, in urban areas in low and middle income countries. So where this paper comes in, so in longer story, I was prior to the COVID-19 pandemic, working with a group that was doing some research on looking at Ebola in the context of the DRC. And when the pandemic hit, we were able to sort of quickly pivot some of that research away from COVID-19, from Ebola towards COVID-19, to then try to answer questions. How did service delivery get affected in the context of the pandemic? So we had a lot of the data to answer this question. And again, that literature suggests that there were short-term reductions in the delivery of health services. That's pretty consistent across every international settings in which we looked at it. The one question that never really got answered is what happened to subsequent fertility, right? So if we would expect these short-term declines in early 2020, but what was the implication of that on fertility in the long run? And so that's where this paper comes in, is that because we had the data, we were thinking, if fertility were to be affected, would we see it in DHIS too? Would we have some ability to pick up on these changes in fertility, basically 7 to 10 months later? So the setting here is Kinshasa itself. So Kinshasa is the capital of the DRC. 7 to 17 million people live there. It's an enormous place. It's a place where the fertility is very high. The total fertility rate pre-pandemic, around the pandemic, was over 6, so that's quite high. Modern contraceptive prevalence was low, but it was definitely on the incline. And what's also really interesting and a bit unusual is that facility delivery rates are actually incredibly high in the DRC, in Kinshasa in particular. So 98% of women give birth in facilities. And so if we were to see changes in fertility, we should expect them to see them in births. Kinshasa was also the site of a very strict lockdown. So in April of 2020, the government locked down in particular one major neighborhood in Kinshasa called Gombe. It wasn't just that this one area was affected, but the major hospital that services a lot of births in the entire area was located in Gombe. So you can also think about it being affected, it affecting the whole area of Kinshasa because that hospital was also isolated. The lockdown went from April to June of that year. It was very strict. All businesses were closed. Public transportation was suspended. However, hospitals remained open, as did pharmacies. And you could go and travel to the hospital if you needed help. But people were basically required to stay home. So this is where the DHIS comes in. We had access to the DHIS2 data, and so we were able to pull and extract data. We wanted data in a pre-period, and as well as through where we might expect to see these fertility effects. We collected data on maternal and child health type services, so basically births and facilities, ANC, PNC, as well as vaccines that we thought would be delivered around the time of birth, and as a falsification, other types of health services. So example, I will present data here on diarrhea, but that's just basically something else. We want to make sure it's not just some sort of residual that's happening in the data. Our data is largely public facilities. There are private facilities in Kinshasa, and that data is not well captured in the DHIS2. In order to process the data, we looked for outliers in which we would delete them, and then we would impute missing data using standard approaches. This This study uses what's called an augmented synthetic control method. I will not get into that here, but basically the idea is because Kinshasa is unique and different, we want to build a control for Kinshasa using as close as possible facilities that looked a bit like Kinshasa in the pre-period. Okay. And again, if we were to see an impact of the pandemic on fertility, we would expect to see it 7 to 10 months later. So what do we find? Again, this is where I have lots of typos, ignore those. But basically, so you can see this is the period in which there was the lockdown, and this is sort of 7 months afterwards. And we put 7 months there because that's where we would expect to start to see it. And as you can see, there is this major increase in births that happens basically at peaks around 9 months later. And it represents about 5,000 additional births a month, which is about a 45% increase in births. Okay, we also find that it's very heavily concentrated amongst young women. We also see commensurate increases in things like antenatal care, which again, we would expect if women were going to seek care. It wasn't as significant for ANCs, definitely significant for postnatal care. We also see that the vaccines that would have been administered to these new baby kids also increased over the same time period. We don't see any impact on other types of health services, which gives us some belief that it really was this increase in fertility that we're picking up in the data. So for example, no change in diarrhea. There is an increase in outpatient visits, not significant, but that's probably also being driven by the fact that ANC and PNC would be counted in those data. So just to give you a little bit, we think yes, fertility increased. That basically suggests that probably the access to family planning wasn't sufficient in that time period and wasn't being outweighed by those changes in economic effects. So that means that we need to worry about that. But for this group, I think there's some really important lessons here also about what we can do with DHIS2. So this is a neighborhood-specific lockdown. Right? This wasn't a national thing. This wasn't a whatever. This was literally 3 months in one neighborhood. And we can see in this very granular temporal data these effects. So we think this is pretty cool. We don't have the data on private facilities, but we would expect to see it there as well. But we definitely were able to pick up some really interesting signal about what was happening in Kinshasa. So just in terms of policy lessons, great, we need to do something about this. This is an important issue. We don't know exactly what would happen. Our data don't give a sense of that. Maybe it had to do with things like intimate partner violence. We don't know, but we definitely know that this is something that was probably a lot of this was probably unintended births. That's a result. This is something that really needs to be built into planning for future pandemics and thinking about how to address these needs in those contexts. So just, I want to give credit to the research team. So these are the people who are also involved in this. Shuo Feng, who is just about to finish up his PhD in biostatistics at Brown. My two colleagues from the School of Public Health at the University of Kinshasa. And that's me. So if you have any questions, please let us know. Keep it fun. Questions, sure. Yeah, okay. Yeah, back on.
Thank you so much for a very interesting presentation. Did you have the data to look at whether these were first pregnancies or multi-parous?
Unfortunately, no, right? So that's not the kind of data that you would be able to get from DHIS2. It's really just counts. We wouldn't know based on, those types of things, whether it was first or second births. We do know, to go further, we do know that a lot of it was amongst women under 20. So DHIS2 in the DRC does disaggregate births over 20 and under 20, and a lot of it was there. So I would guess a lot of it was first births, and again, also suggesting probably unintended births happening at a higher rate, right? Wasn't, planned pregnancies happening. Yeah.
Thank you very much for your presentation. For me, just a comment. Really, it's not a question, because I think this presents your research is really telling us that we need to do more with the data that we are collecting in DHIS2 and I think that is something that we can tap into because we have a lot of data that we could analyze. So looking at this, for example, the teenage pregnancies, I'm looking at now those anticipating such high spikes, and then the effect, for example, on the supply chain for some of these commodities, and then identifying that the pregnant mothers were mostly, that the teenage mothers, and then what is the impact on that on school-going children? What programs can we put in place to have, all that addressed? I think this is really rich, and thank you very much.
Thank you. So I come from a world in which DHIS2 is seen as kind of not great data, right? Of low quality, and therefore not good for doing these types of research. So we did this project in the DRC, which I don't think anyone would be able to put their hand up and say that that's a really strong health system with great, data. And yet we're finding really strong effects. And so for me, what I like about, and it's my paper, I like this paper. What I like about this paper is that it shows you can do a lot with a pretty basic signal. And I agree with you, even better data in the DHIS would tell us even more. But this already, I think, gives us a really interesting insight about something that people, how else would we measure this? In a household survey, you wouldn't even have enough sample size to really detect these types of changes. And here we're finding it.
Yes, hello. Thank you for the presentation. I was just curious on what factors you considered in the selection of the control area.
Yeah, so I won't get into that too much. And I think this is a valid argument because with the way in which you do a synthetic control, I don't know how much you know about this type of approach, but you basically statistically identify a valid type of control area. It's not a real one, it's a synthetic one. You make it up based on a bunch of weighting I won't get into. Basically, you can look at the way in which the data, the variance and so on, comes together. And you can say in a pre-period, this area had a little bit of a look like this period. And so we can say, if we assume that the synthetic thing that we built looks like Kinshasa, we can use that going forward. A very, very, very valid argument about this is that Kinshasa is the major capital city. So there is not really a good comparison like Kinshasa and the rest of the country. There are other urban centers. And so mostly what you'd be picking up is a synthetic control that looked a lot like some of the other urban centers in the DRC. But it is maybe a stretch to use this method in places like this. Yeah.
So first of all, thank you for offering us this opportunity of the call for papers. I think it's very a great one. I would like to see if I have understood it well regarding this call for paper. What I've seen from your study is the quantitative study. In his group,
yep.
In our tradition, we more in qualitative study. That does it mean that the call for abstract will receive qualitative studies?
Absolutely. Yes. So just to clarify, and we'll be around later if you want to talk more about the special call for papers, but Johan gave us this great forming of on, with, and for DHIS2. This is an example of with. We're very open to on and for, right? So, you interpret that as you wish. And we're very much interested in qualitative research. We're very much interested in mixed methods, all kinds of approaches to anything that we think will help advance the role of DHIS2 in research is fair game.
Perfect. And then in that sense, do you have sufficient data to see if there is an impact on what you call family planning? Because there could be, if, for example, the births are increasing, then we could assume that family planning attendance is low, and this could be correlated if we going to the point to the other lady. Maybe we could demonstrate using DHIS2 data that the average age of the mothers has decreased.
Yeah. So, so a couple of answers to that. So one, we actually did write another paper at the beginning of the pandemic that looked at the impact of the short-term impact of the pandemic on use of health services in basically in Kinshasa relative to the rest of the country. We did see a minor decline in family planning, and a few things. And so it's probably related to that, but at the same time too, family planning rates are already quite low. So you wouldn't even necessarily need to see a big change in that in order to still see big effects like this, right? If we think that basically what people are being exposed to is more risk of pregnancy in a context in which family planning is quite low. So it did go down, but I don't think that's the whole story. I think some of it's that, but I also think that it was probably just a lot more exposure to risk. And so that's like getting into the household stuff.
That are giving birth?
We can't do that with DHIS too. Yeah. Yeah, exactly. Yep, sorry.
Thank you. I want to make 2 points. The first one is that you had data that had a little bit of problems. You cleaned it up and you made the data usable. And this, I think, is we don't expect perfect data out of DHIS2, but we expect data good enough to use.
Yep.
And I think that is the most crucial point. And that is what you got with a little bit of, I think there's it. And the last comment I want to make is, how did you get permission to access the data?
Yep.
Because the data, of course, belongs to the government.
Yep. Yeah, exactly. So we were, as I said, we had been engaged in a small project that was supporting the government around their Ebola work. And so we, at that point, transitioned over to COVID. And we did have the data, and we worked with them to support them on understanding what was happening within the health system. That's what they were interested in. We had the data then, they gave us permission to write this paper. But going to the question before, I don't have the data anymore. So any more questions I can't answer because I no longer have access to the data. But we hope that there was some value in us doing this work. Yeah.
Again, yes. Next speaker is Yoshito Kawakatsu from UNICEF.
Yes. Can you hear me? Okay. Thanks so much. So today I want to present our research on the impact of climate hazard on the health service utilization. And this research is conducted under our new initiative named AHEAD. So before talking about the research, please give me some few minutes to explain this initiative. At first, we are UNICEF, but particularly in the DAPAM, we call DAPM. We are responsible for the data analysis, and we also submit several SDG indicators to the United Nations. In these divisions, we started new initiative named AHEAD, that is stand for Actionable Health Analytics for Decision Making, more focusing on subnational level. This is just an example of what we did in Uganda. So usually we only produce national level historically, but from recent years, we go deep dive up to regions and district, and all of this data is using from the DHIS2. That's why we are here. And taking the advantage of DHIS2, we can also do the quarterly and monthly level monitoring up to the health facility level. So we are starting using this kind of analytics and using the automation process. So every district has kind of some products to monitor their performance, and they can start utilizing it in each country. So under this initiative, we started a small project assessing the climate hazard on the health service utilization. As you all know, climate change is happening now, and even the low and middle income countries, the impact must be as massive, but we are not sure how it impacted to the health service utilization. So this research tried to identify, is it true actually impacted to the service utilization, or there are some mitigation measures already implemented, so we may not find any impact. So the objective of this research is to assess the impact of climate hazard on the utilization of essential MNCH services. As the data source, we use the DHIS2 monthly health facility level dataset, focusing on the selected MNCH services from NC to outpatient, including immunization. We conducted this research in 3 countries, but today I want to focus on Ethiopia so that we can focus on the discussion. So in Ethiopia, we have 70,534 health facilities registered their geolocations in DHIS2. So we're focusing on these health facilities. And around 3,000 to 4,000 health facilities are not submitted geolocations. So majority of health facilities reported, but not all of them, particularly private health facilities. And as Nona mentioned, like we need to trace some of the data quality. So before doing some analysis, we conducted some outlier treatment. Using a different methodology, we identified outliers. And this time we just replace these extreme outliers to the mean value so that we can easily explain to the government officers. And for the missing data, in the primary analysis, we didn't change any missing data. But in the sensitivity analysis, we replace the missing data to the mean value so that we can see the difference. To define the climate hazard, for this research, we're only focusing on the precipitation and temperature. We downloaded monthly total precipitation and temperature data at the health facility level from 2000 to 2024. Then we employ the Z-score approach. So if higher than 2 Z-score, we say that is maybe severe rain in the particular areas. The temperature is the same. In addition to that, we saw that the access to the health facility, particularly the load condition, is maybe effect modifier for the climate impact. So we added this indicator in the analysis. And data source is OpenStreetMap. According to the model, we performed a mixed effect linear regression model for each health services and climate hazard, accounting for time, seasonality, and random variation across the administrative areas. This is a model. I skip to explain the details. So this is the result from the model. And particularly, I'm showing the result on the impact of the severe rainfall, because I didn't find any significant impact of the temperature. So in Ethiopia, both severe and moderate rainfall are associated with decline in the essential health service utilization. And additionally, of course, the greater distance to the paved road from health facility is linked to the decreased utilization of the essential health services. In addition to that, the interaction between the rainfall intensity and distance to paved road shows a statistically significant negative effect, especially for the facility-based deliveries. But this impact is not across the health services. So usually research stop here, and then we just discuss why this happening and etc. But we are UNICEF, so we need to translate this evidence to the actions. And from government, usually we say, so based on this research, so which geographic area is a high risk, where we should target it, what is the priority? So we are still like developing how we can do it. So I'm very happy to hear your opinions and new ideas. So what I'm showing is the 2 approach to identify the high risk geographical areas. The right side is showing I just calculated risk score weighted based on the estimated coefficients for severe rainfall and distance to paved road. So in this case, from the coefficient, you can see this. The coefficient of paved road is very small, but because it's a per kilometer, So if very far away, its impact is way bigger than this small coefficient. So in the right side, the distance to paved road is impacted a lot, so that the southern part of Ethiopia is having a high score, it's meaning high risk. And in the left side, we just put a same equal weight for the severe rainfall and the distance to the paved road. So it's become more neutral, but it's not based on the model. So it's so depending on the purpose and demand from country. Of course, there are much different way to do it. So we are discussing with different Ethiopia what kind of product is most essential for them to planning. Then some implementation implications from this research is, of course, we can do some climate-based forecasting. Based on this research, now we understand, okay, severe rainfall, some unexpected severe rainfall is significantly impacted to the essential health services. So maybe we can do some forecasting. And of course, and then based on the high risk geographical areas, we can prioritize the investment in those areas. Then if we cannot prevent those impacts, we can also suggest, okay, in this facility, they receive some severe rainfall. So let's do some additional interventions to catch up those missed services. So as a conclusion, rainfall hazard is significantly impacted multiple health service utilization. At the same time, poor accessibility continue to play a major role. It's long, like everybody talking this access for maybe more than 20, 30 years, but still is a major role. And it's compounding the negative impact of rainfall related disruptions. Then high vulnerability areas should be prioritized and depending on the context specific situation. Then of course we have limitations. We trust that your location of health facility registered in DHIS2, but we already know some facilities may be misregistered or not reliable so much. So that is one of the limitations. Another limitation is that we need to define our methodology for defining climate hazard, risk scoring, and prioritization of health facilities, because access and climate is not only the impact factors to prioritize health facilities. There are lots of contextual factors we need to consider to prioritize health facilities. Thanks so much. And if you are interested in collaborate with us, and particularly under this initiative, we want to know your name and your email. So please take a screenshot or just get us some link from here. Thanks so much.
Yes, hi. Yep. Yes, so first of all, thank you for the presentation. So my name is Anu, I'm from Laos. I just have two questions. So the first question is, I saw your geospatial risk map. Is this map produced outside DHIS2? And my second question is, do you have ever built like a dashboard, like to monitor this like high risk areas? It can be within or outside DHIS2. Yeah, thank you.
Thanks so much. So this map is developed outside of DHIS2. We basically get the data from DHIS2 using API and then do some bunch of analysis and then develop this map. We didn't develop dashboard, but if country requested, we can easily to develop dashboard and then do the like monthly update as needed. It's possible. Yeah.
Yes, thank you for the presentation. I think my question is a bit similar to his. You mentioned that this data is downloaded, so we don't have a real time. So is there a plan to automate the process to allow real time use of this information? And if not, how long does it take to generate this important information for use?
Nice question. So we downloaded data, but through the API. So we can, if you say monthly update, it's automatically update data and then run the same code, generate this one. So it's automated. So one click, do everything. But now we have a like MOU with Ethiopia government. That's why we can do it. But once we lost the access, we cannot do. So, but it's automated system, and we can easy to update this map every month quickly.
Right, thanks. You used the distance to paved road.
Mhm.
I wonder why you didn't take the distance to the whole facility, because we know the status of roads that we have, even the paved one, they could be sometimes very bumpy.
Mhm.
So, using just the distance between to the paved road without considering the distance that is left from when you gain you reach
Mhm.
the paved road and to the facility, maybe the facility is exactly at the point when. So, how did you make the decision of dropping the overall distance from the location to the facility instead of taking just the distance to the paved road?
So this analysis is a unit of analysis is health facility. So there's two way, and one is like from facility to paved road, right? We don't know where the household. So we have facility and paved road, and then there's some unpaved road, like very bumpy road. But we don't know the condition of the unpaved road, and basically, paved road is not impacted much by the lane. That is our assumption. So that's why we include the paved road as an effect modifier. If the paved road is close enough to the health center, maybe the health center is still accessible during the heavy rain. But if very far away from the health facility, maybe this between the paved road and health facilities, maybe there are some unpaved road and affected by rain. So it's the impact of climate hazard become worse than other areas. Is it? Yeah, let's follow up. Yeah. Thanks so much.
Here and see if we manage the. Yeah. Also with the climate health initiative, some of the questions related to that, because some of the maps you make, there's some ongoing efforts also to make apps for DHIS, make it in DHIS to have these. So I think it would be very interesting to list them now. I think there are some parallel sessions on this exactly as we talked, so can follow up that. Okay, thank you, Donna. The last session or last presentation this session.
Yeah, thank you very much. Good afternoon, everyone. My name is Donald Shamba. I'm a senior research scientist working with the Fadara Health Institute in Dar es Salaam, Tanzania. And I'm very delighted today to present to the impact study group. So I will present results from 4 countries, but I will deep dive a bit to Tanzania. Yeah, so the impact study is here, the team, and it is led by Professor Marzio Lazzarini, and I am the lead in Tanzania. So the team and also the national advisory group members and also international advisory group members. So this is study focused on 3 areas, and the first one is on a newborn. And why it's first one is on newborn is because a preventable stillbirth and newborn death still remain very high. And the newborns are the next citizens, very vulnerable. The recent report from the WHO in 2023 showed that a range of availability of key maternal newborn health indicators in routine health information system among 105 countries. And this is one of the reasons that the IMPAS is focusing on ensure there is a quality and use of newborn indicators. And we are glad that last year we presented here, but this is like a continuation. And the previous birth studies also linked it to measurement improvement research. So just showing some of the research studies that we've been conducted in the past years. But these studies are in support of every newborn, every woman everywhere, EWINI, and the 2030 vision of ending preventable maternal and newborn death and stillbirth. Yeah. So the IMPAS study has two phases. Phase one that I'm going to, as I said, I'm going to present the results for phase one. And this was done in 4 countries, as I said, and these are Central African Republic, Ethiopia, Tanzania, and Uganda. We reached 15 regions, including humanitarian areas where it's very difficult, some of them difficult to reach. And in 154 sites, this includes 96 health facilities with the different levels and type. And of course, 58 data offices. So the phase one started in August, was done between August 2021 and May 2024. We interviewed about more than 300 respondents, and this includes health professionals, data professionals, and managers. And do all of this time, we also use the EMN tool. I'll tell you more about the EMN tool, but also we developed 3 new research tools. This include user perspective, health facility functioning, and a neonatal clinical record assessment. So what are the EMN tools? So this stands for EMN stands for Every Newborn Measurement Impact Improvement for Newborn and the Stillbirth Indicators tools. These are open access. You can scan the QR code, so you can have more knowledge or understanding of these tools that I'm talking about. And they were developed based on the PRISM framework and in collaboration with Data for Impact. And they were developed best to support a national program and using for digital data collection tools, and they are automated analysis. So you can just enter them and then you have an automated analysis. So the second into sharing the lessons from the 4 countries. So I will start with the objective. The one we mapped in newborn indicators, data availability in existing routine health information system. So the figure showed reporting of key newborn and stillbirth data elements to RHIS and other system from health facilities. So the pearl shaded data reported to RHIS only most indicators, and the dark shaded to RHIS and the other systems, and the 3 indicators in the center were reported less often. So these are the low birth weight, bag and mask, and the uterotonic. So this is the same figure, but showing all countries now. The reporting indicators, data streamlined into national LHS in Tanzania and Ethiopia, more diverse reporting in Uganda, and limited reporting in Central African Republic. The second objective was to assess newborn data indicator, data quality in existing RHIS. And then here we looked at data quality in newborn register, and also on the left, a newborn case note. So what we found is that on average, 5 registers capturing newborn or stillbirth data in each facility. And then data completeness for numerator was suboptimal. around 79% for neonatal mortality and 81% for low birth weight. And for neonatal case not available, case not except at the subnational level in Central African Republic, and newborn minimum data completeness index showed only 41 data elements, ranged between 43 and 66 overall in all countries. So looking at Tanzania, the PRISM factors to improve the data quality, the figure shows by organizational behavior and improving data quality. Results are heat mapped, and you can see the strength. For example, national score is high. Key gaps that we found are that regional outperformed the district, and health facility lowest, and behavior factors lower across all levels. Use of data for quality improvement only 47%, and the district and the facilities only 28%. The third objective was to understand newborn indicators and data used in different stakeholders in existing RHIS. So this slide shows that Tanzania and Central African Republic, and across organizational RHIS process and using data for decision, data are lower, health facility and then offices, and less data used in Central African Republic compared to Tanzania. Yeah. So this is also the same slide, but now showing Ethiopia and Uganda. And you can see that the different data used, the lower health facility also, than data offices as well. Objective number 4 is to analyze the technical, organizational, and the behavioral enabling factors in the routine health information system to improve newborn indicators and data quality and use. So this is a PRISM framework, which this input factors highlighting in yellow, you can see. And then first, the promotion of culture for information use. So promotion of culture for information use showed different level of health system in Tanzania overall, between 50 and 80%, and the Central African Republic is low, which is between 20 and 40%. So in Tanzania, this was done at national, regional, district, and health facility, but in Central Africa was a bit different at the district level and the lower level. And this is the same slide, but now showing the Ethiopia and Uganda, whereby you see almost the same trends. And now resource availability. So for resource availability, the strength that we found is that computers and printers are mostly available. Key gaps is that all item bundle, very low in all countries and all level, and the electrical power gaps is the biggest challenge across all the countries. So for resource availability, we did some analysis on open text responses that we got. And we came up with these 3 like themes. And one is the paper digital system alignment and the storage for archive hard copies. So for this one in Uganda, for example, the health professionals were saying that give us the proper register for collection of newborn and stillbirth data. Here we only use inpatient register, but sometimes you find that column don't correspond. I don't know what to fill in, for example, in a tuberculosis. So you think that they don't have proper tools and they have to improvise. And then the second one is on to team development for RHIS competencies. So this, the health manager also from Uganda says that they also involve midwife in planning meetings and data review so that they can learn how the data is used. They will learn the reasons why they capture certain data, because many don't know this. So we think this is important because of we know that some of the key challenges in availability of quality of data is understanding what are the indicator definitions. So if they don't know the importance, why they have to, for example, document birth weight and so forth, so it'd be difficult for them to ensure the quality of those kind of data elements. And finally, on the behavioral factors, the confidence levels for routine health information system tasks. Yes, so for confidence, the confidence is limited. In Tanzania, of course, and CAR as well, about 31 to 63%, and competence is very, very low in Tanzania, 7. And the large gap between confidence and competence was realized. And then this is the same figure, but showing another country, Uganda, Ethiopia, that confidence be also still limited, competence very low, and the large gap is also the same, confidence and competences. So in summary here, showing you the overall picture in Tanzania using PRISM framework heat mapped. And for technical organizational factors, health facility is lower in district and the regional level. Behavior factor are lower, showing the graph in red at the middle. And also the process and performance, there are many, many gaps. Yeah. So overall summary of the findings is that the strong performance are in green and the gaps are in yellow. So we found that, for example, on the map on newborn data, most newborn stillbirth data elements indicators are in DHIS2, which is great. But still the streamlined RHIS processes need to be to reduce the burden. And then on improved newborn data quality, so the strong performance, we see that organizational factors for RHIS at national regional data offices is good, but there's a lot need to be done. For example, train health facility staff in RHIS competencies, also to value what they're doing and to improve their motivation to improve data quality. Also to explore case notes and alternative data sources to reduce duplication in registers. And on the use for data, use data for decision making. Yeah, with still strong performance is the analysis report visualization that is done at a district level. And we need to improve the data and the information capture, especially in health facilities and going down, and make sure that data are used at all levels. So that was the first one. And now just a quick highlight on what is planned for phase 2. So this is the IMPAS theory of change linked with the PRISM factors, and then showing the 4 work packages on the left. So the first one is maximizing the impact at country level, DHIS2 optimization, education for peer-to-peer mentoring, and then neonatal case note co-design pilot. So I won't go into detail, but just to show what is going to be done where, or some of the activities have already started. So for example, in Ethiopia, there's a co-creation, there's work package. I'm sure the team are in close contact with Johan here, some in a way with Marzia and others as well. And then that, so the interest is on looking and ensure there's the accuracy and use, yeah, and of course. So Uganda also, the work package 1 and 2 to implementation research with the following component like capacity building, standardized data quality, data validation and use through work improvement teams in the facilities, and then see how best it can be implemented with limited resources. So for Tanzania and Central African Republic, what will be done is that there'll be a co-creation to research and also implementation on education activities for newborn and stillbirth routine data in high mortality facilities. and then also to explore the best use of case notice and do some feasibility studies in high mortality facilities as well. So yeah, more details, of course, on the impact study. You can scan the QR code here, and then that's it. Thank you very much for listening.
Thanks a lot for the insightful presentation. I've seen that you are envisioning to have a standard data quality tool, a quality assessment tool. I wonder if you are moving it from the existing one, because we have quite a lot of data quality assessment tool, and especially in DHIS2, working with WHO, the Global Fund, and Gavi, and so on. We have used RDQA, the standard RDQA, and DQR tools to develop a kind of DHIS2 based tool for data quality assessment. Totally open source that we have already piloted in a few countries, and that could be considered as a complement for your study. Over.
Yes, I think, thank you for the presentation. One question is similar to his. I see that the tools are open source. Are they still in the testing phase? If not, what is their level of uptake so far? And then the other is, what was the level of engagement with the different authorities in the countries where you operated? Yes.
So can I start with this first, and then we can proceed with other questions? That's okay. Yeah. So first, we're not replacing the DHIS2 data quality tools, and then when you talk about DHIS2, so this now you already have aggregated data. While at the beginning I was talking about the registers and then the other different types of data collection tools. So where these tools are aimed to assess from that level, and then coming to link to the DHIS2. That's why I'm saying on the part of the work for phase 2 is linking with the DHIS2 team to start to link from where we've started and with these tools and how best they can complement what existing tools are within the DHIS2. Is that clear? And then in terms of engagement, so the development of the tools were so first of all, there's a two processes we've done. That one was to adapt the PRISM framework and ensure we develop the tool based on the PRISM framework that I've presented here. And then we engage people at the different levels. So first, for example, I can talk more of Tanzania, and which is the same for other countries as well, that the national collaborators at Ministry of Health and the development partners like WHO and UNICEF were part and parcel in guiding the development. And that's why I've shown that the second slide, the national advisors, so include all those people. And also we have international advisors who are sitting at different platforms like a WHO as well, and then measurement working groups for maternal and newborn as well, to ensure that these things help to ensure that we track. First, there is availability of the data. Two, there is data of high quality, and then and ensure that they can be used to measure for measurement. Yeah, so in terms of engagement at all levels, at national and even international level, people are very much involved. And in terms of coverage, that was another question. So at the moment, these tools are used in 4 countries. So Tanzania, Central African Republic, Ethiopia, and Uganda. And then they have been translated in Swahili, English, and then in French. And I'm sure there was Amharic there already. Yeah. So because I focus more on Tanzania. So that at least I know that has been translated, and they also plan to translate in Portuguese as well. So yeah.
Thank you so much. This is not a question, it's a compliment. And building on the question that Kofi here was asking. On quality, yes, we have lots of data quality assessment tools that are both digital, but within DHIS2, we don't currently have a mechanism to automatically verify data that comes within DHIS2. I am from Uganda, and just thinking through the process of the data flow, when data is generated in a facility, it is registered in a register by one person, and then person B will summarize that data into a summary report. And then person C will upload that data from a summary report in DHIS2. But quite often when you're looking at, for example, these maternal and neo stillbirth indicators, if you look at the cascade of that flow, some of those numbers don't match. And it's also in your report, which I've had the opportunity to read. So part of what I think you're talking about in phase 2 is to find a way to automatically verify this data in a very simple way so that corrections can be done by the facility personnel who are generating this data, so that there is correlation on what we are using at aggregate level with what was generated at the facility. Currently, we don't have that verification method, and that's what I think you're planning to do in phase 2, which is really interesting. Thank you.
Thank you very much. Oh, there's a question from UNICEF.
Is there another? Where?
Thanks so much. I'm just curious about the big difference between the confidence and competencies. And in your phase 2, you plan to conduct some capacity building approach. So I just curious, is there any innovative way to train the people, or because previously in those countries, lots of training conducted, they just do also conducted on their own training. So how you want to make sure your training is meaningful and impacted to the competence and competencies?
Well, that's a very difficult question, I might say, because instilling confidence and competence takes a lot of things, including the type of health workers who are working in those settings, resources that are available, and the motivation that they have. This is one of the things that that's why I mentioned, I returned this slide. And these are the gaps that, so we're going to try to push and then instill the culture of information use, for example, because sometimes with another activity that we're doing, we feel so bad because we develop, for example, with this lack of the registers, we develop in Tanzania, develop a neonatal register. And now we are working with the DHIS2 team to ensure that it links with the DHIS2. We're not there yet, but it's going to happen, I'm sure, before the end of the year. And then we've donated the screen to encourage health workers to do data visualization at a facility level. And then to dedicate 1 day in a week so that, like, can we see what we do, what data we have, and then what does it make, tell us, for example, are we improving in terms of our care, and how best we can organize ourselves, you know, or where do we need to put our resources more, and so forth. But you go there on a day that you agree with them that you expect 6 people or 4 people to come. There is only one. The other 2, they say this one is taking care of the babies, and then there are about 30 babies in the room, and you can't pull out to discuss about that. You know, so that's why I'm saying to instill confidence and the competence, it takes a lot of other things. So it's very, very difficult. We try and push where in a setting where there's enough staff, for example, resources. And another thing is governance. Some facilities have the very good managers and very motivated in pushing things but others are very reluctant in change and so forth. So yeah, that's why I'm saying it's a very difficult question to give you a direct answer, because my colleague from Uganda in the morning, she was saying some things can work here, but cannot work in another facility, even within the same region. Yeah.
Okay.
Yeah, there's a question from the back.
Where was the question?
No, I thought you were raising your hand. Sorry. You, yeah. Oh, okay.
So figures and thank you, Simona, for us now 2 sessions with technicalities. For those following the research track, the last session of the day after the coffee break is in the Addis building, full tower 107, room 107, the first floor. So it's not straight over to the auditorium, it's the cooler. Yes. They're outside from the door.